In practical terms, what do you expect to achieve with one of these? I talked about it deferring surgery beforehand. Obviously, you've talked about pain relief, but how long would you expect that to last? Well, how long might you put off surgery for? Do people go without surgery altogether because they've got one of these?
Yeah, so it does depend on the individual. There was a study done, I'm just clicking through to that one, but looking at existing patients that were on the waiting list for surgery, and they actually found that this was done in Bridgend by Paul Lee, now Professor Paul Lee, and he was looking at 63 patients, and they effectively did EQ5D data, so it allows them to do a quality analysis, and they found that it was cost effective in these patients after a period of 4 months, and they were actually able to delay surgery and felt it was both an effective and cost-effective way of delaying surgery in these patients. The mean wearing time for that was 26 months, so they do wear them for significant periods of time.
In just a second, we're going to get on to actually fitting the brace, but dare I ask, what is the cost of one of these things, and what's the route to getting one for a clinician who's got a patient they think might benefit? Yeah,
so there's various different routes. Our biggest customer is the NHS, so these are available through the NHS, and that's the bulk of our work, I would say. The other thing that's interesting with it is certainly private healthcare and these sorts of things. As an orthotist, often, or other allied health professions, private health insurance companies won't necessarily cover anything other than the clinical time. But this is actually the only OA brace that's fully funded by AXA. They will completely cover the use and prescription of the brace.
Fantastic.
So it's unusual in that way.
So if let's say I've got a patient who I think would benefit from this, my best option would be to write to his GP and say, this person has got what seems like unicompartmental OA. Maybe I've got imagery to prove that. I think you would benefit from this brace. Are there nice guidelines which relate to this that we can refer to?
So yeah, there is nice guidelines in regard to bracing in general. I'll skip back through some of the slides, but effectively with those, NICE support the use of bracing in OA where there is associated joint instability, where there's abnormal biomechanical loading, and that really is the important part, just because historically the mainstay of treatment for patients with OA is weight loss potentially if appropriate, patient advice and painkillers. And the difficulty with that is you're very much treating the symptom. You're not necessarily treating the cause of the biomechanical problem. So through using something like this, if we consider that in loading terms, there was a study that found that we're able to get about 15% load reduction in that compartment. It doesn't sound like a lot, but if you equate that to 15% load reduction from a body mass point of view, that's significant, and that's a big commitment from the patient.
So would the GP be able to recommend or refer a patient for one of these, or do they have to go to a consultant to get that?
It varies. Certainly historically, the route through to getting braces like this was always sort of through the orthopedic surgeon. They would then be sent through to either an MSK service or potentially orthotics. It's much more broad now. So there are, for example, first contact practitioners associated with GP surgeries, for example, and they can actually refer on to these types of services. And it's quite varied in terms of who fits and who uses these braces. So orthotists, physiotherapists. There's some plaster techs in some hospitals that actually are fitting them, and OTs, for example. So it really does vary in terms of where you can access these.
What's the waiting time at the moment for a patient to get from making it known to a GP that they think that one of these might be good to getting to the point where they're prescribed one?
Depends where you are. So it can change. I mean, obviously if you're doing it privately, it's significantly quicker, but a lot of trusts are using unloader braces, and the thing is, with studies like the one done by Professor Lee, it's basically showing it as a cost-effective way of doing it, and a lot of surgeons are perhaps limited in what surgery they can do at the moment, so they need something that will actually can manage these patients while they're waiting. And for a lot of people, it does turn into their definitive treatment for the time being.